Okay, with the hour having reached 10 a.m., I'd like to call to order the Cook County Health Managed Care Committee meeting. Roll call.
Director Harrington? Present. Director Webster-Cross? Is absent. Chair Lowry?
Present.
You have a quorum.
Thank you. So no need for remote?
No need for remote unless I see someone join in. And for the record, Bob Ryder is present also, but we don't need a motion for that.
Okay, thank you. Any additions to the agenda?
No, sir.
Public speakers?
No, sir.
All right, I'll now entertain a motion, Director Harrington, to approve the minutes of the Managed Care Committee meeting held on January 31st, 2025.
So moved.
I guess I'll second. All those in favor say aye.
Aye.
All opposed? In the opinion of the chair, the ayes have it. We will now hear a report from Health Plan Services presented by Aaron Galiner, Chief Administrative Officer of Health Plan Services. Aaron, good morning.
Morning.
The floor is yours.
Thank you, Chair, and good morning, Directors. So we'll start off today walking through our typical metrics that we share, and then from there we'll go through an agenda of some various topics around particularly member experience, as well as some of our health equity initiatives, and wrap up with a few strategic updates. Starting with membership, we are at 412,000 members. This is as of March. We're continuing to see over the past few months a month-over-month decrease in membership. So this is a bit of a change from where we've been over the past few months prior to that. What we're seeing overall is that the Medicaid market in Illinois is decreasing. The total enrollment is decreasing. And it seems that that trend is also playing out within our own membership as well. And I'll talk more about that momentarily. So this shows the overall market share. We're at 34.8% in terms of market share. We've been increasing over time in our market share. So, going back over 12 to 18 months, we were previously around 32.5%. That's now grown all the way up to 34.8%, and this has been increasing over the past few months as well. So one of the things we're seeing, as I mentioned before, is that while the Medicaid market overall is shrinking, that our membership is decreasing at a slower rate than the rest of the health plan. So we're actually gaining market share through that process. So there's a bit of a silver lining within the overall Medicaid market trends. The next slide shows some of those trends graphically. So you can see on the right-hand side, that's overall Medicaid managed care enrollment in Cook County, the red line. You can see that decrease that I mentioned that we're continuing to see. And so it was much more dramatic during this large wave of redetermination that was happening last year. It's flattened out, but is still decreasing over these past 6 months or so. You can see our membership on the left. Of course, we brought on the HBIA, HBIS populations, so we saw increases early last year, then was impacted by that large redetermination wave, as we all know. And then our membership has sort of flattened out and varied with some increases and some decreases. This data is through January, which is what's published from the state. When we look at the past few months in terms of our membership from January through March, we've continued to see, as I mentioned, month-over-month decreases. They've been relatively small, so on the scale of 500 to 1,000 members per month, so half of a percent impact in our total membership, but that is a trend that we're continuing to watch. The next slide shows membership as compared to our budget. So red bars is the budget projections, blue bars is our actuals. You can see we're exceeding the budget still pretty significantly through these first few months. A lot of that was we headed into this year performing better than expected on redeterminations, which put us ahead of the game in terms of what the budget projections were. I will note that the HBIA program, which the governor's budget proposal announced would end July 1st, will impact about 16,000 to 17,000 of our members. And so once we get to July, we'll see a significant drop there and probably be right in line with budget projections at that point. So when we look in terms of the total year and the budget impact of our membership, we're expecting we'll still land at or ahead of budget, but we will see some impacts in the second half of the year from that HBIA change. This slide shows our overall operations measures, including our call center. No real call-outs here. We've continued to see good performance here. We've been monitoring this very closely. We are trying to expand some of the work of our call center to not just be able to transactionally answer questions and deal with issues that they're getting incoming, but also being a tool for outreach and helping members close care gaps and being able to leverage this more so that when a member calls in, we're able to educate them if they're up for redetermination, if they have a care gap that needs to be addressed, that we can help them potentially schedule appointments and be able to better support the member in that moment when we have a connection with them.
Could you provide some examples of care gaps?
Yeah, a really simple one would be, have you had a PCP visit in the past year? The next slide shows some of our disease prevalence. So these are some new slides that we've added just to contextualize disease states we're seeing within the plan. So you'll see this broken down by a few different demographic categories, but I think not too surprising here. Some of the typical chronic disease conditions are most prevalent with the plan. So hypertension, diabetes, asthma, and COPD, as well as significant behavioral health needs within our population. The next slide shares some of this broken down by age. So you can see that obviously different disease states lead the way based on the age of the population. So when we look at the pediatric population, asthma is our leading condition. As we look at the adult and older adult population, hypertension, diabetes are really the ones leading the way.
Is asthma primarily with the pediatric or?
Correct. Yep, primarily with pediatric. Certainly we see some of that in the adult populations as well, though we also see more advanced.
What's the percentage?
In terms of COPD?
In terms of patients?
In terms of the asthma diagnosis, I can get that back to you. I don't think I have this broken out on the slide, but we can provide that by age category to you.
Yeah, I was just thinking there may be some opportunity with the schools and some other places based on.
Yeah, in the pediatric population, again, I'll confirm the numbers, but it's still a relatively small percentage of the population, but obviously it's still the most common condition.
Yeah, but what I'm thinking about is rushing kids to the emergency room for things that might have been prevented based on treatment.
Yes, absolutely, and we're starting to look at some data around that too. So there's HEDIS measures that are around asthma medication ratio, for example, that we track. We're also trying to look more deeply at our pharmacy data to evaluate use of preventive inhaler use, for example, versus emergency inhaler use to understand if we're seeing members that are just continually refilling their emergency inhalers, but not using consistently their preventive inhalers to help better control their asthma conditions more preventively. The next slide shows this broken down by gender. Again, I think pretty consistent results here. And then our next slide shows this broken down by race and ethnicity. So again, continuing to see higher rates of chronic disease disproportionately across our most underserved populations, which I think is not unfortunately unexpected. The next slide.
Yeah, I just want to make a point. This is not necessarily due to race, it's because we've looked at it on the basis of race, but it has more to do with where people live and the resources that are available to them.
Yes, absolutely. And to your point, resources available, specialty care that's available in many of these neighborhoods, and so that's something that we're also monitoring in terms of how we build out our network, and trying to target specific geographic areas where we see disproportionate amounts of providers, and trying to fill in our network to drive more access in some of those areas, and also trying to leverage telehealth as well to try to fill some of those access to care challenges.
Aaron, as we, and if it's in here, please point it out, as we go forward with the sharing of pertinent statistics, let's make sure we also are showing raw numbers. For instance, there may be a situation where 23% of a population is receiving some type of care or resource, but we're at a point like Medicaid where we have to be able to show in raw numbers how many members of the white community are being affected by certain things, how many members of the African-American community, et cetera. That's very important information for us to have, especially as we work closely with our friends in Washington. Okay, thank you.
Absolutely. All right, so heading into some of our policy updates, we're still in a bit of a waiting cycle right now for federal policy. We know the budget reconciliation process is underway at the federal level. There is significant concerns about the potential for significant Medicaid reductions as part of that. So we are anxiously awaiting that process to play out. There's been a number of different potential discussions around the Medicaid program, including everything from reducing federal funding that states receive to support the Medicaid program, different provider assessments, work requirements. So there's been a number of different proposals that have been thrown around, all of which have varying impacts, I think most significantly within mainly our Affordable Care Act adult populations are likely most at risk from some of the proposals. At the state policy level, as I mentioned, the most significant change is the Healthy Benefit for Immigrant Adults sunsetting of that program, which is proposed in the governor's budget proposal and would take effect July 1st. That impacts about 16,000 of our members. And then there's some other legislative topics being discussed in this legislative session, including some bills around prior authorization limitations, pharmacy benefit manager oversight. None of those we have significant concerns about in terms of the impact to us at the plan. And then our team was down in Springfield as part of the Association of Medicaid Health Plan Lobby Day this past Wednesday, and so had, I think, a number of good conversations and an opportunity to discuss the Medicaid program and the importance of that program to our members and to the state. And the next slide, as I mentioned, talks about the Healthy Benefit for Immigrant Adult impact. So as I said, about 16,000 to 17,000 individuals are impacted. Letters have been sent out to this population, making them aware that their coverage will be ending as of June 30th. The way this is currently designed, it is a hard coverage stop. So individuals that are in an inpatient setting would continue to have their care covered through the course of that inpatient stay, but if they're receiving any sort of outpatient treatment, even if that's ongoing treatment for a diagnosis, they would lose coverage as of July 1st. And so we're working through some of those potential transitions and ensuring we can leverage our Cook County Health clinics as well to try to support individuals who may be in some active course of treatment to ensure that they don't lose that treatment even though their coverage may be changing.
Aaron, what about the HBIC category? What's the status?
So the HBIC's Healthy Benefits for Immigrant Children, those are categorically eligible under the standard Medicaid program, and so there's federal funding that the state receives for that. We don't believe at this point that that's at any type of risk from a state policy perspective. The state's kind of put some more definition around that category, but those individuals have been a part of the Medicaid program for really since the inception, and is part of the traditional kind of children's Medicaid program.
Thank you.
All right, and with that, I'm going to hand it over to Christy to talk about some of our member experience initiatives.
Great. Good morning, directors.
Good morning.
My name is Christy Terrain. I'm the Chief Plan Officer and Interim COO for County Care. And I'll just add, there's also no change for the Health Benefits for Immigrant Seniors program. And then for folks that are pregnant, that program is continuing, so there's no interruption there. So for member experience, we have set the objective to create the best possible member experience with comprehensive benefits, an engaged, empowered membership, and exemplary customer service. That's our objective for 2025. And last year, we achieved the 90th percentile for rating of health plan for children and the 75th percentile for rating of health plan for adults, which was really exciting. That's one of the measures that contributes to our NCQA rating. So we received 4 stars last year. That was partially a contributor to us receiving those 4 stars. This year, we have a goal of achieving the 95th percentile for both adults and children, and we're currently in the CAP season. So I'll tell you a little bit about how things are going with CAPs. If you go to the next slide. So the CAP survey is the Consumer Assessment of Healthcare Providers and Systems Survey. It's administered once a year. We also do ongoing surveys of our membership once per quarter just to get a sense of their feelings about the health plan and also make sure that we can continually make improvements in member experience and satisfaction. Questions are set by NCQA, the National Committee for Quality Assurance, and it's sent to a statistically significant number of members, and we are currently in fielding. So surveys got sent out at the beginning of March, and we're going to be continuing to survey our members through May, and then we'll start getting some of those preliminary results to understand how we're doing. So
those are paper surveys?
They're telephonic over the internet, and so members can respond to a QR code on a survey that's mailed out, and then we also have a team that's reaching out to them. It's a third party that conducts the survey.
Yeah, and I know some institutions are using text messages to collect the information, which might be faster.
Yeah, that's a great idea. People can still contribute to the survey via the internet, but that's a great idea. If you go to the next slide. So some of our key messages are around some of the measures that we're trying to impact most. So getting needed care and getting care quickly are all about people being able to access their care. We have made some improvements over the last year around expanding our urgent care sites. So we're now at 150 urgent care sites. We've also been contracting with telehealth providers, and then we implemented a new transportation partner that went live last August. So those are some of the messages that we've been getting out via our campaign and social media. We also launched a new website for the CAPS campaign. For rating of a health plan, the key messages are around our 4-star NCQA rating that we received last year, and that we received 5 stars in women and children's health for the health plan report card through the state of Illinois, and then just that members are choosing county care. Over time, we've seen that more and more members are choosing to come into county care. For those that aren't auto-assigned, folks have an opportunity to select a plan. And then for rating of all health care, we have really been ensuring that folks know that it's really important to see their primary care provider, and last year, over 70% of county care members went to their PCP.
Yeah, I have a question or two. You indicate we have 150 urgent care sites. And what patients call in and you refer them, or do they know where these sites are?
So they're listed on our website. We actually have a separate call out on our website for all of the urgent care sites where they can do a search of those. And some of them are already embedded within our existing provider network. But yes, they can get referred through our call centers if they call into us. If they reach out to their care manager can help support in getting them connected. But otherwise, they can use our provider directory and find the urgent care sites in our network.
Yeah, and there's a difference between emergency care and urgent care.
Correct.
Sometimes people don't know the difference. They wind up in the emergency room where they could go to a clinic, and are we helping people understand that difference?
Yes, we have information in our member handbook and on our website. We've also done training with our call center representatives and care management teams on that.
We also will do some follow-ups, correct me if I'm wrong on this, Chrissy, via text messages for after we see emergency use for conditions that may be more appropriate in urgent care. We'll send follow-up text messages after they've discharged from the ED that following week to provide some education about urgent care opportunities too.
It would be interesting to look at the relationship or just urgent care versus emergency care. And I don't know if we would know how many of those emergency room visits were really something to be handled at an emergency care setting.
Yeah, we can often be able to see an indication of that in our claims data. So yeah, that's a great contribution. If you go to the next slide. So over time, we have been implementing an overall strategy to improve our member experience. Part of that is with outbound outreach as well. So we just launched a new outbound outreach call center in partnership with Chicago Lighthouse. We'd had an existing relationship with them and have expanded upon that. So really the goal is to increase our member engagement rate. We are required by our contract to outreach to all members for welcome calls, but really had a pretty low connection rate, and so want to make improvements there. We also are working with them to help complete health risk screenings and also close care gaps. So do outbound outreach to help support people with scheduling and staying on the phone to schedule them for PCP visits, for prenatal care, if they're having trouble getting access to care. And if you go to the next slide, so we just have some very preliminary results. We just went live with them in February. So as you can see on the left, in January, we had about a 3% connection rate. That was with our former partner. In February, we saw a connection rate of 28.56%, which was a huge increase. And then for our welcome calls, we've seen that be consistent through March as well. And then we just launched our Care Gaps campaign that went live in March, and we have seen about a 70% connection rate so far for closure of care gaps, which has been really positive.
So Lighthouse is the primary, or you mentioned Lighthouse, right?
They're our partner that's completing these outbound calls on behalf of County Care. So we've been working in partnership with them to support and doing outreach to our members. They work within all of our systems, so it's as if they're an extension of our team. Yeah,
could you let everybody know what Lighthouse is?
Sure,
Everybody
Chicago Lighthouse.
Lighthouse.
Oh, so sorry. Chicago Lighthouse is a non-for-profit organization for folks that are low vision or blind, and they have worked with us for a really long time in supporting call center functions. They also worked with County Care in completing health risk screenings, and they've just provided really excellent customer experience, and we've seen that over time. So kind of when we were looking to improve these services, look to them as a partner to help support in this. And we're seeing that from those connection rates, that people are staying on the phone and willing to work with them.
So we're helping employ people that have some visual problems.
Exactly.
Which is really
yes.
commendable.
So I should know this, but I don't. As we sit here, do we have any telehealth pods either here or at Provident? And if not, as we continue to resource our hospitals, are we thinking about that as a possible direction?
We've talked about, on the provider side, looking at potential virtual, I don't know if we're going to go into pods or a tablet, kind of a room or whatever, but virtual capability where to, address the question around urgent care versus ED, patients can potentially self-select. So we have to ensure from, EMTALA that they're getting triaged and that they're stable and all of that. But if they choose themselves to take a virtual option, then that could be a way to allow them to avoid, an ED wait and all of that kind of stuff.
Sounds great. Good.
And we're also, with this partner, we're going to be working to set up a way to schedule appointments directly in Cerner as well. So that's kind of a next step in that partnership. If you go to the next slide. So we also, just in April, launched our new text message vendor, which is was an opportunity for us to look at all of our messaging going out by text to make some enhancements. We also, as opposed to just having text messages in English and Spanish, now have them in Arabic, Ukrainian, Mandarin, and Polish, and, as well as Spanish and English. If you go to the next slide. For health equity, our objective and key result is really focused on reducing health inequities through the creation of opportunities for our members to access care within their communities, and also to address their health-related social needs. So we have two key results that we're really focused on. One is to achieve our NCQA health equity accreditation, and the second is to continue to work on identifying and addressing health-related social needs for our members and their communities. We've really focused over the last couple of years on housing, food, and transportation, and we'll continue to do so. If you go to the next slide. So for county care members, almost 1 out of every 3 members reported that they needed help with either food, clothing, or shelter. This was through health risk screening data. We also had more than 1 in 3 members report poor health, and we know that we need more access to different kinds of housing services. So this has really been an area of priority over the last several years. And if you go to the next slide. So we have a variety of different partners that we've worked with over time. Back in 2020, we were able to use some of our quality withhold funds to reinvest into the flexible housing pool to house some of our members. We also received some additional funding through ARPA to be able to house even more members through county care. We have a partnership through the Illinois Housing Development Authority and Wind Recovery. So overall, through all of our housing programs, we have just over 430 members who've been housed. And the Flexible Housing Pool is a permanent supportive housing program in collaboration with cross-sector partners. We contributed, as I mentioned, through our withhold dollars of $5 million back in 2020. We just added an additional $3 million to that investment to increase sustainability and support of our members that are already housed. And we've been prioritizing individuals with substance use disorder and county care families with children. And so really the goal of this program is to increase housing stability, income, improve outpatient utilization, and then lower emergency department utilization and jail recidivism, emergency shelter days. We have, over time, seen some really great results related to this program.
Have you shared the results with us?
We would be happy to do so. If you go to the next slide, there's some of our outcomes. So this is a study that was completed by the HRSU, the Health Research Solutions Unit here at Cook County Health, and the amazing work of Dr. Keiki Hanami. So they had done a study from 2018 through 2021 related to the overall flexible housing pool population. So this included 1,300 folks in 800 households. We saw an overall 97% program retention and a reduction in inpatient stays, a reduction of emergency department visits, and jail registrations, and also overall cause mortality. We are currently working on an evaluation for the county care cohort that we funded, so we'll be happy to share those results once we have those.
This is phenomenal, and this is one reason why I recently asked that we schedule a county care presentation for my colleagues, on the Board of Commissioners. Quite simply, they don't know everything you're doing. So I think this is great because not only are you detailing the different initiatives which are impacting the community in Cook County, but you're showing the fiscal impact, and that is just vital. So thank you for your good work.
Thank you. And so what's coming next in housing? We just completed a housing RFP and selected 2 partners that we're going to be working with in contracting to support transitional housing, permanent supportive housing, and wraparound supports. And this is very much in alignment with the state's 1115 waiver and the state's plan to expand housing services. So since it takes us a little while to get through the RFP process, we wanted to start early in making sure that we were able to implement and be ready to go live in January when the state plans to have these services rolled out for the 1115 waiver. Okay, so we're going to switch gears a little bit and briefly talk about our accreditation. So we just completed our reaccreditation last year, and so nothing stops in accreditation. You start the cycle right over again. So we're working through completing our evidence for this year, and then we'll be going through our overall NCQA reaccreditation in 2026. We've decided that we also want to add another distinction to that for long-term services and support. So we're currently in the implementation for our long-term services and supports distinction, and ensuring that we can prepare and be ready for accreditation in 2026. And then there's also an accreditation through the National Committee for Quality Assurance for health equity. It's a best practice, and it's also something that we see could potentially be included as part of the state's RFP going forward. So right now, we're in implementation, ensuring that we have everything ready to go so that we can apply this fall, and then also work to gain health equity accreditation in 2026 as well. And on the next slide, we have a pretty busy timeline, which I'll just paraphrase in sharing that we have a lot of work going on around accreditations, all three of those accreditations at the same time. We are going to be working to close this year's evidence this summer, and then have our second year's evidence beginning so that we're prepared to submit in 2026. And then we'll be applying for health equity accreditation, as I mentioned, to be able to submit our evidence in the summer of 2026 as well. If you go to the next slide. So I believe this is our last and final slide, but we just wanted to give an update on the Health Choice Illinois RFP. It's definitely top of mind for us. We have completed 2 drafts of the RFP response already, even though it hasn't dropped. So it was originally scheduled to be posted last year. They decided to basically delay that, and it's going to be released this summer based on all the information that we have. And new MCO contracts would take place in January 1st of 2027. So we're all ready and set to submit our RFP response this summer, and then we would be going through implementation for the new contract to start in January of 2027. Any questions about that?
Director, you have anything further?
No, good work.
Thank you.
Great work and great report. Thanks to both of you. We appreciate it. Okay, so the next regular meeting of the Managed Care Committee will be held on Friday, July 18th, 2025 at 10 a.m. And with that noted, and having no further business before this committee, I'll now ask Director Harrington if you'd move for adjournment.
So moved.
And I'll second. We're adjourned, and have a wonderful weekend, everybody. Thank you.
Thank you.
I didn't get a chance to do this.